Hello, everyone, and welcome to today's webinar, Community Health and a Better Future Through Philanthropy. Before we get started, I would like to go over a few items so you know how to participate in today's event. You have joined the presentation using the computer's speaker system by default. If you would prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. Today's webinar is being recorded and you will receive a follow-up email within 24 to 48 hours with the link to view the recording. I would now like to introduce Pam Norley, President of Fidelity Charitable. Pam?
Thank you. Thank you so much and welcome everyone. We're really excited to have you with us here today to learn more about how giving can make communities across the world healthier for us all. But before we get into the conversation, I just want to acknowledge the strong grant making Fidelity Charitable donors have done since the beginning of the year. Our donors have recommended a record $5.5 billion in grants just since January 1st to over 125,000 charities across the world. And that increase in the first half of the year follows our record-setting year last year, where 9.1 billion went out to about 270,000 charities. So just really proud to be able to help you with your philanthropy, and obviously there continues to be a lot of need. So, and as we continue to define our new normal, and as we see the pandemic continue to impact our lives with the Delta variant of the coronavirus, we know there is much more work to be done. Particularly and especially over the last year, we know the devastating impact the virus and disease can have on the most vulnerable populations across the world. And we also understand how, more clearly now, how interconnected we all are, and how the impact on strengthening health can improve everyone's life in a community. So I'm so excited for our discussion today. We have three objectives that we want to accomplish. One is we want to share a very powerful story about a well-known donor, how he used a systems-based approach to tackle a highly complex problem with philanthropy. Secondly, we want to build on that story, and you'll learn about the significance of strong community health and how giving in this area can transform an entire health system, potentially containing and preventing the spread of disease. And then finally, we want to share some ideas for how you can forge successful partnerships with nonprofits, no matter what cause you care about. So through stories and insights you hear today, we hope that the conversation will inspire and empower you to act and think differently about how you work and partner with nonprofits to support your causes. I'm delighted to be joined today by a true visionary in the field of community health and the co-founder of Partners in Health, Dr. Paul Farmer, who's asked me to call him Paul, and New York Times bestselling author and philanthropist, John Green. Paul is the co-founder and chief strategist of Partners in Health, and among other many credentials that would take me way too long to list today, he's also the chair of the Department of Global Health and Social Medicine at Harvard Medical School, and he's the chief of the Division of Global Health Equity at Brigham and Women's Hospital in Boston. He's dedicated his life to improving healthcare for the world's poorest people, and we're privileged and honored to have him here with us today. We're also privileged to be joined by John Green. Many of you know John as a New York Times bestselling author, social media personality through his YouTube channel, The Vlog Brothers, but he's also made giving back a real focus since the success of his many books, including The Fault of Our Stars, Turtles All the Way Down, and his recent essay collection of The Anthropocene Reviewed. John will share his philanthropic journey, including his powerful work in Sierra Leone in West Africa, in partnership with Partners in Health, and how he used a systems-based approach to trying to drive long-term sustainable change. So John, so let's get started. What motivated you to give back? You know, what motivated you to give back? Why community health, and why Partners in Health?
Well, for us, for my brother and me, it really started in childhood because both of our parents worked for nonprofits. My dad spent most of his career with the Nature Conservancy. My mother is a community activist and has been for a very long time. And so the moment my brother and I got jobs out of college, there was immediate pressure to begin giving back. And so we've tried to make it a part of our lives for a long time. But when my book started to become very commercially successful, in some ways I was kind of overwhelmed by choice, by feeling like there were so many problems. I didn't know where to start. I didn't know what to do. My wife and I would talk about how important global health was to us, how we saw, the unequal access to healthcare and educational opportunities as, really justice problems, core problems to the human experience. But we didn't know what to do with that or what to do about it, and it just felt overwhelming. There are so many problems, so many people trying to address them. For us, it really began with listening, trying to listen carefully to people who are experts in global health, but also listening carefully to people who are affected directly by the work that these organizations are doing. And we heard over and over again that what was really making generational long-term differences were systemic interventions, attempts to strengthen the entire healthcare system so that it better served people, from the level of community health workers making house calls and checking on people to make sure they can take their medication, all the way up to secondary care at hospitals, making sure that people can get safe surgical procedures and stuff like that. And when we asked people who's making these systemic differences in the poorest communities in the world, we heard Partners in Health again and again and again. And so we went to PIH and we said, we're interested in finding a way to work with you. Where do you see immediate need? Where do you see immediate opportunity? Where do you have the deep partnerships with governments, with other nonprofit organizations that's going to allow y'all to make those systemic differences? And they came back and they said Sierra Leone. And so, we didn't choose Sierra Leone. It has the highest rate of maternal mortality in the world. It has one of the highest rates of child mortality in the world. And we share PIH's belief that if we can prove that a stronger healthcare system can lead to radically better healthcare outcomes for mothers and children and other vulnerable people, that, a lot of the excuses that the global health community uses to say, well, we can't do it there, we can't do it in a place like Sierra Leone, it's too poor, the infrastructure is too weak, et cetera, et cetera. If we can make the case that no, it is possible, that it can be a blueprint, that was very inspiring to us. But the main thing that was inspiring to us was people we trusted and who had a wonderful track record saying that this was where they saw the immediate need.
Good. And so Paul, he comes to and reaches out and says, we want to focus on where there's immediate needs and where there's already good, strong partnerships in place with government. What, how did you approach responding? Is that the first time you had been doing work in Sierra Leone? I know you've done a lot of work, obviously, in Haiti and Rwanda and other parts of Africa.
It was, just by sheer happenstance, I made my first trip to Sierra Leone in June of 2014. And we had been organizing back to the systems model, how do you address problems like maternal mortality or an acute abdomen like appendicitis? You need surgery, and surgery is one of the complicated parts of this work, right? It requires staff, support, and above all, systems. I should have said space. So staff is like surgical nurses, space is like an operating room, right? The stuff, everything from anesthesia to scalpels, and the systems is how do you make it available to everyone? So we ended up going there, even though we knew that an Ebola epidemic had already started. And a number of our colleagues, most of them surgical colleagues, said, well, we shouldn't have a meeting there. And, I said, not glibly, but I said, well, that's not how Ebola is spread. It's not spread through attending medical conferences. That's Legionnaire's disease. And we knew that we were headed into a very difficult situation. John mentioned strong government partnerships, but it was a weak government to start with. And it was really, just to use some shorthand, a complete clinical desert. And a clinical desert where there isn't the staff, space, and systems you need is also, of course, a public health desert. So, deciding for me to go, or a group of 100 or so people going to address surgical care in resource poor settings, is of really no significance for patients. What you needed was hundreds, if not thousands, of people to come together. And that's really when the Green brothers and the Green family, rather, got involved early on, as we were, trying to really survive and help other people survive a devastating epidemic that went on for a couple of years. So I would just say our friendship and our working relationship was forged under very difficult circumstances, but having committed, as Partners in Health did, to a long-term health system strengthening project meant that we needed more and more allies from across the world. And this is an organization with roots in the United States and Haiti, and so we really turned to the United States and Haiti for a lot of help. I mentioned Haiti because when you do focus on staff subspace systems in sport, then you have to train doctors, nurses, administrators, and a very large number of our leading protagonists really are Haitian. So off we went, and I was just there recently, and the difference even now, in spite of all the problems we're seeing with COVID, is really quite remarkable because of this systems focus and commitment to not sweeping difficult problems, cancer, Ebola, mental illness under the carpet. So it's really work that's going very well. It's uplifting on a daily basis, and that just can't happen without the kind of partners and allies like the Green family.
So John, back to you. So you identify Sierra Leone, you identify you're going to work with Partners in Health. What did you do a strategic plan? I mean, how did you approach, number one, identifying how with the systems approach you were going to get after this, and two, then how much money you were going to need to execute against that vision and the plan?
We began in an emergency. And so we didn't begin with a plan. We began with an emergency, the emergency of the Ebola epidemic. And there was a huge amount of resources that went into Sierra Leone and Liberia and Guinea. I mean, tiny relative to what is needed, but huge relative to what had happened before, to try to address the Ebola epidemic. And then as it began to wane, I think Partners in Health co-founder Ophelia Dahl once said that you could hear the giant sucking sound of money leaving to deal with the next crisis or the next headline. And Sierra Leone's healthcare system was weaker than it had been before in a lot of ways. 15% of Sierra Leonean healthcare workers died of Ebola during the epidemic. A lot of the woefully inadequate facilities were even more understaffed, were even less well supplied. And so there was still an emergency and there was still a crisis. It just wasn't an emergency or a crisis that was receiving a lot of attention. And that was really the moment where we began talking to PIH about what could be a long-term plan. Ophelia Dahl likes to say that long-term problems require long-term solutions, and we took that on board and began to internalize that reality. It's hard to overstate how impoverished the healthcare system in Sierra Leone was in 2015 and in 2016. The only mental hospital, almost nobody could receive mental health care. The only dedicated psychiatric facility in the country had no medicines, no ability to keep their patients safe. And so many patients were still chained to their beds at night, and sometimes all throughout the day. The maternal care facilities were just utterly inadequate. No electricity, no running water, just shockingly inadequate. And so we recognized that this was going to be a long-term, very expensive problem, and that frankly, Hank and I didn't have enough money, we just didn't. And so we understood from the beginning that we would both have to give a lot of money and we would have to raise a lot of money. We would have to work with, PIH's donor network, and PIH does a great job of that. But we'd also have to work with our audiences, our community, to try to work together to raise the kind of ongoing money that this really requires.
Good. Let me go back to you, Paul, in terms of talking about a systems approach. Can you unpack that a little bit? I mean, you're talking end to end, right? You're not talking technology, bringing in infrastructure. It's just a real systems way of thinking about everything that's necessary to address an issue.
Well, it's also particularly hard to keep a systems approach in mind in the middle of an emergency. But we'd already lived through that a number of times in Haiti after the earthquake, for example. And one of the things we learned in Haiti before the earthquake was that, building a clinical facility, even if you had the right staff, space, and systems, was not enough to take on a lot of illnesses, including any chronic illness. Maybe you could have a good trauma service, a physical trauma service, but imagine having a trauma service for mental trauma after an event like that. That requires long-term outpatient care. So you've got hospitals, you've got clinics where people would get something like preferably they would even get vaccines at home. But where you can imagine you'd go if you had a cough and needed a chest x-ray. And then finally, the real key to the system is the community health worker. And that's where you have people representing the communities in which they often grew up as the living links between a village or a town or a neighborhood in a city and these institutions, the kind of institutions I work in, like a hospital. So we learned that in Haiti in the 80s and 90s. And we also had this amazing experience in the last 15 or 20 years in Rwanda, where we got to see the idea of a system like that scaled up to a national level. Everybody talks about scale and end-to-end scale, as you said, Pam, but it's really a remarkable thing to dream about it for decades and then see it actually happen in what was a fairly short amount of time. So we knew when we went to Sierra Leone and Liberia that we wanted to emulate that. And the interesting thing, and I'll stop here, is that the health authorities we met with, and even the national political authorities, they knew about Rwanda's success. Everywhere across that continent that we went, South Africa, North Africa, even in the United States and Europe, people know about what Rwanda has pulled off. And since we got to be a part of that, we wanted to take those lessons and apply them in West Africa. And of course, we called on our Rwandan colleagues to help us there. So that's how we really got going. We said, we're not going to ignore the critically ill in front of us, because when people are sick, what they're looking for is not systems, they're looking for care. They're looking to survive in this case. And we knew we couldn't ignore that. We'd seen it happen too much in public health endeavors. So while we were doing the acute response, we were also thinking about how can we open these hospitals? How can we open these clinics? How can we recruit and train community health workers? And we felt like it would be a winning formula, and happily the authorities and population certainly agree with us on that.
So John, back to you. Define for me, like when you think about a community healthcare worker, you think about somebody who is working in a facility or is part of a system that already exists. I know you met community healthcare workers in your visits and journeys. Can you share that with us and kind of what that is defined to be in a country like Sierra Leone?
Yeah, and I think this is one of the places where we need to kind of expand our understanding of the kinds of exchanges that can happen when we have better sharing of resources and better sharing of expertise. So, because we often think of philanthropy as a sort of one-way street, as people with resources giving money to people or giving resources to people without resources. I think that is on a lot of levels the wrong way to think about philanthropy. When this stuff is working, as Paul was saying, it's really an exchange of expertise. People who have been trained at the teaching hospital that PIH supports in Haiti now work in many different communities, and not just in Haiti, in Liberia, and lots of different places. Community health workers are a great example of this, because we have all around the world many examples of healthcare systems that run with very limited resources and that we could learn from. And right now, I feel like we don't necessarily always do a great job of learning from them. So PIH, for instance, ran or still probably runs the contact tracing for COVID-19 in Massachusetts and in other states, using expertise from other people who work for PIH around the world. And community health workers, I think, show us a way forward for our healthcare system and for others, because these are the people who make house calls, who go within their community, within their neighborhood or their village, visit with patients who have chronic illnesses like HIV/AIDS, make sure that they are able to that they have access to medication, but also that they're in a position to take it. When I traveled around for a day with a community health worker named Ruth, and the first patient she visited said, I'm struggling to take my medication, not because I don't have the medication, but because I have to take it with food, and I don't have any food. And if I don't take it with food, it makes me very sick and I can't take it. And Ruth had a kind of expertise that I'll never have, and was able to say, if you drink water with some sugar, and here are some, we have resources for nutritional stuff, and here's this, but also just for today, if you drink water with a little sugar, it's easier to take, because Ruth takes these medications every day, just as her patients do. And we visited with, families with children with tuberculosis, and so Ruth was checking in on these people 2 or 3 times a week in a lot of cases. And that is what allows for successful treatment of tuberculosis in these communities. Those people doing that work are as essential, if not more essential, than having the medicines, than making sure that the medicines are stored in a climate-controlled environment and all that stuff. And so when Paul talks about the 4 S's of staff, space, stuff, and systems, you really need all 4.
Right. So did you have a certain, like, as you thought about the money that you were going to donate to support change in maternal health and obviously mental health issues in Sierra Leone, did you have like an outcome in mind? Did you think like, okay, this is what I want to make sure gets done, and that you were tracking, so you felt like you were really driving change and impact?
Yeah, I think that's really important. But I also try to remember something that my friend Logan Smalley at TED told me once, which is that it's easy to confuse what is easy to measure with what is important. And when it comes to like standardized testing in the United States and lots of other things, like sometimes we go with what is easy to measure instead of really spending the time to think about what's important. And so being able to quantify results is extremely important to us, but we also want to make sure that we're measuring the right things, and that we're measuring them at the right time with the right time horizon.
Yes.
So it is something that we thought a lot about. We thought a lot about the scale of the project that we were going to be able to do. Like, we're not going to be able to raise $250 million for Sierra Leone's healthcare system to radically reshape the healthcare system in the entire country. And so we started in one district where, PIH is active in one district. And when they reached out to us, they came to us with a scale and said, if we had $25 million, we could do this over the course of 5 years. And Hank and I said, well, we don't have that much money, but we can try to help find it. And that's what we've been doing for the last few years.
And that's in an effort to build this Center for Maternal Health.
Yeah, and really to strengthen. So it's building a maternal health center. And Paul, correct me on all of my mistakes here, but it's also about strengthening the whole healthcare system in the Kono district of Sierra Leone. And the Maternal Center of Excellence is key to that, because that's the epicenter of maternal mortality in the world. 1 in 20 women in Sierra Leone can expect to die in pregnancy or childbirth. And we know that is not, we know that there's nothing inevitable about that number, because 3 years ago it was 1 in 17, and 3 years from now we believe it can be 1 in 50 or 1 in 100. And so that was the first. That's kind of the anchor of the project, but this is about the whole healthcare system. This is about supporting more community health workers, making sure that clinics are adequately stocked, that they're well staffed, and that they have electricity and running water, that they have the ability to provide care, which in a lot of cases, unfortunately, they really don't on a lot of levels. And strengthening the hospital so that the hospital can be a place that people can trust that they will get good care.
So, and Paul, so you've done this in Haiti, Rwanda, you mentioned Liberia, now Sierra Leone. Is your goal to kind of come up with a templated blueprint approach that you can take to other countries who are suffering so severely to be able to encourage them to drive the level of systems change that's necessary for long-term sustainable results?
Well, I think that even if the goal were not to come up with a template like that, we should do it anyway. I mean, the goal is to reduce suffering caused by disease, as we all know. When you think about maternal mortality, you are also thinking about family planning, prenatal care, all of the other things that go around it. But to save someone in distress during pregnancy, you actually need a highly functional hospital system with blood banking, et cetera. So we did have the template that I mentioned that came from Haiti and was really brought up to a very impressive level in Rwanda. But I think, we also wanted to go in with humility about, well, is it the same thing they need that we saw in urban Peru, for example? So one of the first things we want to do is kind of get a sense of the burden of disease, like what are the leading 5 killers of young adults and children and women and the elderly, whatever, right? And where are the gaps in responding to them? In Sierra Leone, the gaps were just massive, right? And that's in large part not because of Ebola, but because of the civil war, the famous Blood Diamond War, that it really ended only a decade before Ebola hit. So they were already dealing with the crisis of not having staff, space, and systems. And in the peacekeeping efforts that followed the war, that ended the war, in fact, there were not a lot of investments in the kind of security John and I are talking about, the social security of well-being. It was more soldiers, UN troops, et cetera. So, we went in with a template in the sense of experience. We went in with some humility in the sense of saying we need to understand what's the burden of disease and what are the gaps. And then we went in knowing that we would find communities and health officials who would want to work on this, and we haven't been disappointed in that regard. The degree to which this can be sped up, of course, is meaning across a national level or a regional level, varies for lots of reasons, but they mostly are the same ones that we had encountered in Haiti and Rwanda and Malawi and Lesotho, et cetera. And then if you look at the United States, which of course I do as an American physician, you look at the systems failures that we had in the first 18 months of the COVID response, where we had the highest number of deaths in spite of massive resources that were unavailable elsewhere. And so how else would you explain that except to say there's serious systems failures in the United States care delivery system, which everyone agrees upon, but I think the full magnitude of their cost was rendered visible to a lot of people. And that's probably one of the reasons so many Fidelity Charitable folks pitched in over the last 18 months to help respond here and elsewhere.
So what learnings do we have? I mean, unfortunately, I still think we're not through on to the other side on our pandemic. What learnings do you have, for example, from just even the work with John's family in Sierra Leone from the pandemic that you would want to think about and applying as we think about other long-term challenges that we're going to be facing with?
Well, one of the things that I saw in Sierra Leone in 2014 to 2016 and had seen many times before, but not in the United States, was a control over care paradigm where all the focus was on disease control and not on responding to what people are asking for, which is care, not control. And the roots of that are in colonial medicine. And it's really a 20th century phenomenon in Africa, right? It's really recent history. And then came war, et cetera, et cetera. And so, the lessons we learned about control over care were certainly familiar in other parts of the post-colonial world. Here we saw something very different. It would be a non-starter in the United States to say, look, we're sorry that you have COVID. We can't help you. We're all about preventing COVID. That's not going to fly, nor could you have radically different standards of care endorsed as policy. Like in a city like New York, you can't say, well, this is the Manhattan standard of care. For the Bronx, it's something different. Now that is how it has played out.
Yes.
But and that's again related to the systems failures, right? But here in the United States, we really saw and abandon too often of the control function, right? And you know, the highlight of it was when the president of the republic got sick with COVID, and you know, his chief of staff said, we're not going to stop COVID through contact tracing, mask wearing, social distancing, but through vaccines. And I think right now in the middle of the Delta variant, we've seen again how short-sighted it can be to have a care over control approach as well. You really need to have both disease control and compassionate, humane care for all those who need it. And I think that's a template that we need here in the United States very much.
So, so thank you, of course. And so, John, back to you. So, are you in it for good? Is this is your commitment for your lifetime and your family's lifetime to Sierra Leone?
Yeah. I mean, I will die at some point, but until then, for sure. Yeah, just to quickly piggyback on something that Paul just said, I think another big takeaway for me is the profound interconnectedness of humanity, which, you know, those of us who live in wealthy countries can sometimes feel very insulated from, and can sometimes feel like, you know, the problems of people who live in poverty are very distant from us. We you know, and certainly people who live in impoverished countries, their lives can feel very distant from ours. But that is a fundamental misunderstanding of the way that humanity works. We are one species sharing one planet, and you know, as long as over 1 billion people don't have access to basic primary health care, including many people in the United States, we are putting all of ourselves at risk, because this is a profoundly interconnected human story. But as for the rest of our lives, yeah, I mean, this is the work of our, you know, this is the work of our lives, and we understand that it's very long term. You know, when you see real generational change, is, in my experience anyway, in my observation, is through long-term, very long-term systemic support and interventions. Those are the things that change things over decades. We know that every time a mother survives childbirth, that child is far more likely to have more educational opportunities, far less likely to be malnourished. And that's a generational change. And so every time at Koidu Government Hospital, a mother survives childbirth who would have died 3 or 5 or 10 years ago, that's a potential generational change. And yeah, we expect to be involved in that work over many decades.
Good. So let me go back to the third objective we had for this conversation, which is, you know, how our donors can work to forge successful partnerships with nonprofits. And maybe I'd turn to you, Paul. What is it that you see in the people that support Partners in Health that makes them a good donor, that makes them feel committed to your cause, makes them feel that they're driving long-term sustainable change and having impact with their contributions? Are there specific things that people do, you know, that they think about and approach working with Partners in Health that we should consider sharing?
Well, I mean, it's a delicate topic, Pam, you know, because a hard-bitten analysis of this would just get back to John's point and say, well, we need people who are humane, compassionate, and committed to long-term engagement. Maybe they're bankers or in finance or writers, you know, or bloggers like John and Hank, whatever, you know, can you have the humility required to go long-term on this, you know? And you know, sometimes that runs very counter to a trend in philanthropy to look for the newest, best, you know, what is the game changer? You know, how can we work ourselves out of a job? Why would we want to work a Sierra Leonean community health worker like Ruth out of a job? You know, she should be able to participate. She already has as a patient, but she should be able to participate as a protagonist in this drama, and that isn't going to happen with that kind of long-term support. So, you know, I think we know it when we see it. You know, when someone says, "Look, I'm not trying to impose my little pet idea on you know, this charity or NGO or implementing agency, but rather to express my commitment to the laudable goals of trying to attack health disparities like this. And they're so dramatic when you go to a place like Sierra Leone, that I think another thing that we should be doing more of, and this is on us, is to have people more deeply involved in the work. That is, our supporters, our,
Yeah.
and our board members are all supporters of one stripe or another. Some are very wealthy, some are academics, some are survivors of illnesses themselves and have been our patients. But bringing us in and saying, no, global health is not just for doctors and nurses. Global health's for everybody who's human. And I think we are making some progress. And I also am wondering if the pandemic hasn't opened a lot of eyes to this problem.
I mean, I think one of the things we've seen with Charitable, with Fidelity Charitable donors, is that they have been giving in an unrestricted way. So, in the past they were giving to support a particular program or feature or something, and now it's about, they understand that the people closest to the mission have the knowledge and expertise and confidence to actually, put that money to work in the best way that they see fit. And that's been in my opinion, a very positive development.
Yeah, I think that's really important. And, that's been a big focus for us. I mean, we learned that, I think, from our parents because they came from the nonprofit world and did a lot of fundraising. And, but I need to go into this knowing that I am not an expert in global health, and I need to listen to the people who have a lot more experience than I do. And I need to, and that includes the people who are actually doing the work that we're supporting, and it also includes the patients who are being supported by the work that we're trying to support. So that's the first thing for me. The other thing for me, though, is that when my book, The Fault in Our Stars, became kind of suddenly commercially successful, my wife and I, our initial thought was like, we started this Fidelity Charitable account, and we were like, let's build this up so that one day it can be really big. It's like, it'll grow and grow and grow, and then one day it'll be so big that we can do a lot of good. And this idea of like growing the money was very important to us initially in the first maybe 18 months after The Fault in Our Stars came out. And that was really our focus. And then when what we eventually have come to believe is that the money is growing. It's growing in the form of kids who survive past the age of 5. It's growing in the form of fewer kids being malnourished. It's growing in the form of tuberculosis being cured in a higher percentage of patients. It's growing in the form of mothers who survive childbirth. It's just not growing in the way that we thought of growth. And so for me, expanding our definitions of growth, expanding our definitions of what the money can do as it grows, was really important, I think, to being or to hopefully being a better partner to PIH.
Great. So we're running up on time here, but we have a lot of questions that have been coming in. And Paul, the first one is, we're getting a lot of questions related to are there any domestic opportunities here in the U.S. where donors can be focused on kind of taking this humanitarian long-term view approach to address and drive sustainable change?
Oh, for sure. And, we're not really so much about the nation state as a unit of analysis, and of course have really deep roots in the United States. And as John mentioned, I think he mentioned just now, Partners in Health has been deeply involved in the COVID response across the state of Massachusetts, but in Florida and California with the Navajo Nation, many other places. That's been another source for us to kind of take these lessons often learned in Haiti, Rwanda, Malawi, Lesotho, and apply them here, I think, to good effect. But it's also expanded our engagement because understandably, people are interested in serving and often close to home. So I think some of those opportunities, well, put it this way, Partners in Health has recently had, often 15, I'd have to ask Sheila Davis, the director, for the numbers. She was also, before she became director, the head of PIH's Ebola response in West Africa. But, we've often had close to 2,000 people working, often with community health workers, and in addressing the awful health disparities that we're seeing in this country and have long seen, and which again are now revealed to the whole world.
Another question.
Just as an example, I would say, you know, sometimes there's school teachers. Can school teachers get involved in global health equity? Sure, they can. Can researchers, can administrators, can people, I mean, look at again, going back to Fidelity Charitable, look at people come from all different walks of life to come and participate in this. So I think it could be a kind of golden age of engagement in health disparity work, which would lead, one hopes, to a golden age in addressing health disparities.
Somebody's asking the question, how is your work in Haiti going now, Paul?
Well, you know, it's been a really tough couple of months. I mean, it's an astounding thing when a sitting head of state is assassinated like that. And so I don't want to minimize in any way the effect that's had on our work. But you think about what we've described as a system: community health workers, clinics, hospitals. And what I can tell you is that my courageous Haitian colleagues, and they're really almost all Haitians you know, working in our Haitian sister organization, have kept all those institutions open through you know, a great health crisis and a very significant political crisis. So maybe they wouldn't tell you what I'm going to say, that I think it's going very well. And part of that is because I'm so proud of what they've managed to do under these difficult circumstances. They're already vaccinating people with mRNA vaccines. And Partners in Health sister organization has also served as the national clinical referral center for COVID-19 cases.
Good. Well, we have way too many questions to be able to get to and answer. A lot of them are very personal about, you know, where should they give their time? Where should they give their money? How do they take what one of the questions, John, is how do I get my kids to be as excited about learning as you and your brother are? What did your parents do?
Well, I can assure you that my parents would have been asking the same question when I was in high school. So yeah. I was not a good student, and I have become a committed advocate for education opportunities for people who do not present as good students, because I definitely was not a good student. I was just really lucky to have teachers who didn't give up on me and parents who didn't give up on me. And I'm sure you are that type of parent as well. I know it's not easy now that I have kids myself. I suddenly understand how challenging I must have been as a teenager, but yeah, good luck.
Yeah. Well, thank you so much. We, you know, as I anticipated and as we discussed in the prep session, you know, we knew we were going to have way too many things to talk about and jamming into 45 minutes, but I'm so appreciative of your time and insights and sharing of your stories. I think it's stories that really, I think, bring things to life. So thank you so much for that. You know, as I reflect on the conversation we've had, I think I want to emphasize two things that I took away from it. Is one is, again, the listening, taking that listening centric approach to understand how to really work with a nonprofit organization and bringing a humble self to that experience and opportunity. And then two is identifying the right nonprofit to work with. And that takes exploration and research, but you know, we've got 1.5 million nonprofits in this country, and we've got to figure out how to work with ones that are collaborative, involved, on the ground, you know, have taken a long-term view to trying to drive some intractable issues to be addressed. So thank you so much for your time. I think we're going to include some helpful resources for our viewers in our follow-up email. I want to encourage everyone, if you have a chance, to watch the Netflix documentary, Bending the Arc, available on Netflix, as I said, which tells a remarkable story about how Paul and his colleagues started Partners in Health. We're very excited. We've got another webinar coming up in October on the 19th to talk about education and the importance of education, particularly at this time when you know, there's still much uncertainty about where people are going to be in terms of getting an education, whether it's at school or at home. And so we look forward to everyone joining us for that. And with that, I want to thank everyone again for joining us. And thank you again, Paul and John. It's really been a privilege. Thank you, everyone, and stay safe. Bye.